Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. I'm a little shocked. I've got an email asking me to do a podcast on prednisone, and I totally anticipated. I've done that one, but I have actually not done specifically prednisone. It is part of my top 200 list that I completed a few weeks back, but today I'm going to get into prednisone. First, I wanted to mention, go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Definitely a no-brainer to have that. Simply an email will get you access. So, moving on, prednisone, very commonly used medication. Brand name is Deltazone. This is classified as a corticosteroid. Also could be classified as an immunosuppressant type medication, anti-inflammatory type medication as well. In my practice, the most common reason I see this medication used or indication, it's used for many inflammatory conditions, asthma, gout, rheumatoid arthritis, acute situations like pneumonia and dermatitis. So any type of situation where we've got significant inflammation going on, that prednisone can help relieve that inflammation, obviously make the person more comfortable, and help alleviate that situation. Dosing with this medication for those inflammatory conditions, it's typically a short-term course, 5 days, 7 days, maybe up to 14 days in rare cases. And usually you're going to see 10 to 60 milligrams. I'm talking for adults here, of course. I would say most commonly I probably see the 20 milligram dose utilized for those acute type situations. Occasionally you'll see a 30, 40 milligrams. But again, kind of 20s, probably what you see most common for acute relief of inflammatory type issues. So how does it do this? Prednisone reduces inflammation by suppressing migration of polymorphonuclear leukocytes. Prednisone also suppresses the immune system. So in addition to the anti-inflammatory properties, you can see this medication utilized for renal transplant, liver transplant, basically any transplant you can think of. And that's to prevent that rejection, essentially, of the organ that's transplanted. And it does this, it suppresses the immune system by lowering the action or activity of that lymphatic system in the body. The other mechanism or the other action that's one of its primary roles is it does suppress adrenal function at high doses, and this leads to potential risk for adverse drug reactions. And the first one I want to mention is HPA suppression. So, defining that a little bit, HPA is the hypothalamus pituitary adrenal axis, HPA. So this basically has kind of a negative feedback loop in the body. Prednisone is a synthetic corticosteroid that mimics the action of cortisol in the body. So this is the hormone that's naturally produced by the adrenal gland or the adrenal cortex. So when you take prednisone or any corticosteroid, especially for a prolonged period of time and or at higher dosages, it tells that brain, basically the hypothalamus pituitary gland, to reduce the production of what's called ACTH. So that's adrenocorticotropic hormone. And this is part of the feedback system with that HPA axis. So if the adrenal glands aren't seeing as much of that ACTH and they aren't being stimulated by ACTH, so over time they can actually shrink or atrophy, whatever you want to call it, and that function goes away. It doesn't function as well. So this is known as adrenal suppression or adrenal insufficiency is what that's going to be called. So this can be a real big problem. Again, on prednisone, longer periods of time, higher dosages, you can basically stop the action of that system and prevent the body from making its own cortisol, or at least inhibit the body from being able to produce its own cortisol when we've been giving it exogenously from outside the body. So it kind of shuts down that system. So when we stop prednisone abruptly in patients who've been taking it for a long time, we can basically run into this adrenal crisis where the body can't recover fast enough and produce enough cortisol quickly enough. So this can be an issue, lead to ultimately a life-threatening condition, an adrenal crisis there. So big challenge there. Hopefully that all made sense. But basically, prednisone, higher dosages, longer periods of time. We have to be really, really careful, and we need to taper slowly if a patient's been on prednisone for a long, long period of time. So we're talking months, maybe even potentially years, depending on how long they've been on it and how high the dosage is. Okay. So that's kind of one of the first, adverse drug reaction things I wanted to mention. On an acute adverse drug reactions, short-term adverse drug reactions, GI upset, definitely common with corticosteroids. Prednisone is an oral corticosteroid, so taking that orally can increase the risk for GI upset, can increase ulcer risk as well. Generally, this medication is given with food and or milk to help kind of alleviate some of that issue or prevent some of that issue. Insomnia, anxiety, this medication can kind of ramp you up a little bit, so that is definitely a complaint I've heard from patients. So pay attention to that. Typically, we want to take that prednisone earlier in the day to try to hopefully get used to the medication a little bit, and maybe those concentrations are starting to go down as we get more towards nightfall and patients are able to sleep a little bit better. It does exacerbate diabetes, so it causes hyperglycemia. This can be really troubling to patients. I've seen this a lot where patients are previously pretty well controlled with their diabetes, and let's say they have an inflammatory issue, skin reaction, maybe an asthma reaction, that type of thing, where they need some systemic corticosteroids. That acute use of that prednisone will cause significant increases in those blood sugars, and you can get patients that normally they're in the hundreds, and they can spike up into the 200 and 300s, and they're like, what the heck? What the heck is going on? So can be a little bit difficult sometimes to figure that out because it can be infection related. If there's an issue that way going on that have kind of caused some fluctuations in the blood sugars. But obviously, giving a steroid like prednisone can cause that issue as well. So definitely pay attention to that. It happens all the time in practice. And if you make adjustments to the diabetes medications, you're probably going to have to adjust them back if they were well controlled previously. Can cause some elevations in blood pressure, may exacerbate heart failure a little bit as well. So a couple cardiovascular things there to keep in mind and pay attention to when we're using this medication. So we really want to do our best to kind of minimize corticosteroid use because of all these side effects. On the long-term side of things, there's potential increased risk for elevated intraocular pressure. So this is problematic in patients with glaucoma or those at risk for glaucoma. Immune suppression risk. So naturally, if we're using it to suppress the immune system in an organ transplant, for example, that suppression of the immune system can be too much and can greatly increase our risk for an infection happening as well. HPA suppression, hopefully I explained that. Longer term, higher dosages. We really got to be careful about tapering and doing it the right way if we're trying to get patients off this medication. And then osteoporosis risk I wanted to mention as well. Definitely something that comes up there. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like pharmacotherapy, ambulatory care, NAPLEX, BCM-TMS, geriatrics, go check out meded101.com/store. We've helped thousands of pharmacists, pharmacy students prepare for their exam. We can absolutely help you too. So all those links, all that information, meded101.com/store. All right, wrapping up on drug interactions. First one I always think about is that hyperglycemia risk. It can directly oppose what we're trying to do with, insulin or GLP-1 or whatever diabetes medications we use. Pay attention to that for sure. GI toxicity, GI bleed risk, definitely really, really important to pay attention to that. Get many patients taking over-the-counter NSAIDs for pain relief, for example, and adding prednisone on top of that can increase that risk for GI toxicity and bleeding. CYP3A4 inducers as well as inhibitors. These can mess with prednisone concentrations a little bit. Not something I'm crazy worried about typically in shorter term use. I think it's just something to kind of monitor and recognize that CYP3A4 inducers will reduce concentrations of prednisone and ultimately the actions of prednisone a little bit. And inhibitors may increase concentrations. I would say it's probably a little bit more risky, a little bit more sensitive in patients where we're using prednisone for immunosuppressive purposes, like in organ transplantation. So that's probably a little riskier scenario than, let's say, somebody that's getting 20 milligrams of prednisone for 5 days for an asthma attack. Okay, so again, kind of weigh that risk, kind of see what they're on, and if they're on these medications, recognize that concentrations may fluctuate a little bit, but it may be more or less risky, kind of depending upon the situation. A couple of other things to think about. Tendon rupture. So, occasionally I see quinolones used, let's say for pneumonia type situation, and I may see them used in combination with a corticosteroid to help with the inflammation and other things going on there. So tendon rupture, tendinitis risk is associated with quinolone antibiotics. So that would be a medication like levofloxacin. Corticosteroids like prednisone actually increase that risk further. Okay, so something to pay attention to if you've got a patient at risk for that and they are taking quinolone antibiotics. And then the immunosuppressive action can certainly be additive. So if you've got a patient taking, tacrolimus or cyclosporin, those are immunosuppressive type agents and can have additive effects on top of prednisone. And then the last thing I wanted to mention was in relation to vaccines. So it's recommended to avoid live vaccines during and 1 month after therapy with immunosuppressive doses of corticosteroids. And this is definitely something I've seen come up on board exams. Well, what is considered an immunosuppressive dose of a corticosteroid? So in adult patients, that cutoff is typically considered to be around 20 milligrams. So if you're taking 20 milligrams or higher, that's considered to be an immunosuppressive dose. And it's recommended to avoid live vaccines during the time frame you're getting that prednisone and for a month after therapy is done. Okay? So ideally, if you know a patient is going to get prednisone, ideally we'd like to give those vaccines, weeks prior to them getting prednisone. But a lot of times we don't know that, right? An acute situation comes along and we've got to give prednisone. So if it's strategized and we know we're going to start using prednisone, in the coming months, it's definitely good to get those vaccines done. Non-live vaccines, so it's recommended to give vaccines at least 2 weeks prior to immunosuppressive corticosteroids if possible. So if patients are vaccinated less than 14 days prior to that prednisone therapy, so let's say, on a Monday they get an inactivated vaccine, and then Friday later in that week, they have an issue, they have something going on, skin reaction, whatever, and we give prednisone, 20 milligrams, we would want to repeat that vaccine at least 3 months after therapy, recognizing that immunocompetence has been restored. So again, kind of pay attention. If you know a patient that's been on and off, prednisone periodically, they use it, that type of thing, recognize vaccine schedules and paying attention to when they should get vaccines, and that prednisone is going to suppress that immune system, and we shouldn't be giving vaccines with that prednisone, and we should have some spacing there, which I laid out. So again, very, very important, I think, to recognize that whenever we use immunosuppressive agents, definitely look it up, try to look at the individual vaccine that we're wanting to give, and making sure that it's okay to give and that we're not going to have to basically redo that vaccine. All right, well, that wraps up the podcast for today. Thank you so much for listening. Please do me a favor, leave a rating review on iTunes or wherever you're listening. Support the sponsor, meded101.com/store. Lots of books, study materials, all sorts of good stuff for virtually every healthcare professional that's looking to learn more about pharmacology. So go check that out, support the sponsor. If you want to reach out to me, comments, suggestions, all that good stuff, Eric Christensen, PharmD, BCPS, BCGP. You can find me on LinkedIn. You can also email me at mededucation101@gmail.com. I'm going to sign off for today. Thank you so much for listening. Please share the podcast with all those that may benefit from pharmacology education, and I hope you have a great rest of your day.